Good evening, everyone. Good evening. My name is Scott Kratz. I'm the Vice President for Education here at the Building Museum. And tonight, we present a program entitled Healthy Hospitals to discuss the confluence of sustainability, healthcare, and the built environment. This has been a rich topic to research over the last 6 months, and here are some facts to consider. By 2026, the nation's population over the age of 65 will double to 71 million people. Hospitals currently use twice as much energy per square foot as office buildings. According to the National Coalition on Healthcare, the total national spending on healthcare in 2007 was $2.4 trillion, or $7,900 per person. That represents, that total healthcare spending represented 17% of the gross domestic product, or GDP. U.S. healthcare spending is expected to increase, reaching $4.3 trillion in 2017, or 20% of GDP. In 2008, hospitals added 110 million, that's 110 million new square feet of construction, which represents a 25% surge for new hospital projects, according to McGraw-Hill Construction. Everyone's concerned about the health of your family, your community, and indeed your own well-being, and the built environment that we're here to discuss this evening plays an essential role in designing a more sustainable and healthier world for us all. We've assembled quite an impressive panel tonight, representing a range of viewpoints, and I look forward to an in-depth discussion. This program is part of our series called For the Greener Good, Conversations That Will Change the World. And the goal of the series is to bring together the world's leading experts from different disciplines to discuss relevant issues of our time. We would like to thank our funder. The For the Greener Good series is presented by the museum's sustainability partner, the Home Depot Foundation, and we would like to thank them for their generous support of this innovative lecture series. If you like what you hear tonight, I would like to give 2 quick plugs for upcoming programs. On April 29th, our next For the Greener Good program will discuss a panel on the future of food. Participants will discuss how buildings and structures can be transformed to provide sustenance, and how the production and transportation of what we eat plays a critical role in how our cities look and function. The panelists will include Carolyn Steele from Cambridge, an author of Hungry City, How Food Shapes Our Lives, Robin Osler from Elmsley Osler Architects, Dixon DePommier, a professor of public health at Columbia University, and the moderator will be William Thompson, the editor at Landscape Architecture magazine. I'd also like to invite you to one other program, a presentation on April 2nd by a good friend of the museum, Dr. Howard Frumkin, who is the director of the National Center for Environmental Health and the Agency for Toxic Substances and Disease Registry at the Center for Disease Control and Prevention. Dr. Frumkin will be discussing the link between planning and public health. And that program augments our Green Community exhibition located up on the 2nd floor. If you haven't seen it yet, I encourage you to do so. It's open through 2009. Tonight's program is designed to incorporate your questions and thoughts, as all the series have been, and they're meant to be conversational in format. So the moderator, Joanne Silberner, will break periodically during the audience to take questions. And it's helpful for them as well to see who we have in the audience tonight. So by just a show of hands, the architects in the audience. Great, architects are well represented. Planners, wonderful. Landscape architects, great. Engineers, wonderful. The students, great. Federal or state employees, that is great. That's helpful. We have quite a panel for you this evening. I'm going to give the briefest of introductions because otherwise I'd be up here all night talking about our panel's accomplishments. And then we can get right into the discussion. Bob Eisenman is the Executive Director of the Global Health and Safety Initiative, a sector-wide collaboration to transform the way that healthcare designs, builds, and operates its facilities, as well as the products healthcare uses within those facilities. Prior to launching the Global Health and Safety Initiative, Bob worked in public policy, community and government relations, leadership positions for Kaiser Permanente. Robin Guenther, principal at Perkins & Will, is the co-author of Sustainable Healthcare Architecture, an amazing book. Robin served as, thanks Joanne, Robin served on the 2010 AAA Guidelines for Construction of Hospitals and Healthcare Facilities Revision Committee, and has more than 25 years of experience in designing and advocating for high-performance, sustainable healthcare environments. Roger Ulrich holds the Beal Professorship of Health Facilities Design and is the faculty fellow at the Center for Health Systems and Design at Texas A&M University, and has led some of the pioneering work quantifying how green hospitals can indeed be healthier ones. And our moderator for this evening is Joanne Silberner, who is the health policy correspondent at National Public Radio, where she covers medicine, health reform, and changes in the healthcare marketplace. With that, please welcome Joanne and the rest of the panel.
Well, I, for one, am thrilled to be here, and I agree with Scott. The best thing to do is to be quick so we can get right to our panelists. I'm going to ask a few questions to start things off. I'm going to referee them a little bit. If they use terms I'm not sure we all understand, I'll make them go back and get to that. And I'm going to push them to come up with solutions, not just defining situations, defining problems, but I'm going to see what kind of solutions they've got, because these are three very creative people. And I'm going to start with the first question, which I'm going to send to Roger, because he really started it all with his landmark study back in 1984. It's View Through a Window May Influence Recovery from Surgery. And I'm not an expert in the field, but it's pretty clear to me that when people talk about rational design of hospitals, this is what comes up first and foremost, that it can make a difference in how a patient feels. So I'm going to start with Roger with a question, with a definitional question, and then we're going to move on to problems and solutions. So Roger, the question for you is, what exactly is evidence-based design? What do you want to see happening in this idea of sustainable and green hospitals?
Evidence-based design, Joanne, is a kind of analog to evidence-based clinical medicine. And I'm applying it to medical design here, but it can be designed, conceivably applied to any building type. And it really is just the deliberate process of design wherein that process is informed by the best available evidence. For some issues, we don't have scientific evidence, but increasingly we have very good scientific evidence that pertains to a number of important outcomes in medicine, such as those pertaining to safety. And really the goal of evidence-based healthcare design is to create hospitals or other healthcare buildings that are highly effective, that perform better, that are safer, that are more healing, they're better places to work, better places for family to visit, and they help to reduce long-term costs. So they improve outcomes in a broad sense. You get your money back, and you get your money back rather quickly if you invest in smart, good design, and if you pay a bit more at the outset.
Do you want to go through a pluses and minuses sheet? Where are the costs and where are the savings?
Well, let's think in terms of two very general time phases. One would be the construction of the building itself. And if let's set the cost of building a U.S. hospital, say arbitrarily a large community hospital for $500 million, and we'll assign that a proportion of 1, and that's a circle about like this. And that initial capital cost is huge, particularly in these times when it's more difficult to get capital. Down the line, say if we take a 30-year operations time frame, which is a typical one, that $500 million, which seems so huge, is actually quite small relative to the cost of delivering high-quality care in that building for 30 years. The salaries, the medications, the technology, all of that. In fact, currently, the ratio is at least 15 to 1. So the operations, the cost of delivering care in that building over 30 years is going to be at least 15 times higher, and for certain high acuity groups, it may be 25 to 30 times higher. The message from evidence-based design is if you focus too much on the short-term initial capital costs, you don't build it smart based on evidence, and you build it cheap, it increases the size, the annually recurring costs on an annual basis over 30 years. Basically, you hemorrhage red ink. And that big bubble gets a lot bigger. And that's very relevant to the cost problems we face today in medicine. Quality goes down. If you spend somewhere from 5% to 8% more at the beginning and do it in an evidence-based way to create a smart, safe, sustainable hospital, then this will have rich economic consequences and outcome consequences in a positive sense, in a whole life sense. The message is, there's a real pitfall here to focus too much on short-term initial cost minimization. And if that's done, you really pay. It's a short-sighted, economically irrational perspective that unfortunately is all too common, not only in this country, but in other countries.
Robin, I'm going to give you the 5 to 8% more. What are you going to do with it?
Well, you know, it's interesting because there's a hospital in California, Palomar Pomerado, that's in design right now. And they actually took a package of improvements that included everything from single bed, same-handed, acuity adaptable rooms to solar shading devices and energy conservation features. And they divided them into 3 buckets. They had the sustainability bucket, they had the kind of single-bedded room bucket, as it were, and then they had the other evidence-based design improvements, whether those are ceiling lifts or a whole range.
Sorry, ceiling lifts?
Ceiling lifts that take patients, help you lift a patient out of bed and move them to the bathroom. A whole other list of improvements to the physical environment. And roughly the buckets were equal on about an 8 to 9% premium, with roughly 2.5 to 3% sustainability, 2.5 to 3% in the rooms, and 2.5 to 3% in the rest of the, in the rest of the features.
I mean, this is in cost?
Yes,
So
in
each
capital cost.
Each bucket costs 2 or 3%?
Right, exactly. And we are just in the Green Guide for Healthcare has just kind of finished a study of.
Do you want to tell us a little bit? Does everyone know what the Green Guide is?
Do you know what that is? Yes. We've just been reviewing the data on 14 of the first LEED certified hospitals in terms of first cost premiums that projects report. And it's interesting that 4 of those 13 projects didn't report any premium. So that's roughly 30% of them said they accomplished their sustainability goals within the budget for the building. That's generally the way people talk about no premium. There's a budget, the team and the owner and the design team manage the budget, and they deliver the project for the budget.
So 8 or 9% more?
No, not 8 or 9% more. They sort of said it worked. We fit it in to the budget that was derived. But the question of how budgets are derived in healthcare capital is always an interesting exploration, right, for those of us in the room that do that for a living. Anyway, but more to the point is another 60% of those projects reported somewhere between 0.5% and 2% in capital cost increase to deliver sustainable features. That's all we asked them about. We didn't ask them about evidence-based design measures in the building. We focused on the green design. And only 10% of the projects said more than 2%. And the highest project reported 3.8%. So none of these sustainable projects were on the order of magnitude more than what Roger's talking about as a piece of an overall package of capital improvements that increase the initial cost. And I think it's an evolving marketplace because, as we all know, what we consider to be a baseline standard design evolves over time. And that's both because of programmatic changes, equipment changes. There's, it's really a moving target to define what's a baseline standard practice hospital in the United States. It varies a little by region, by marketplace, et cetera. So the numbers are all a little difficult to pinpoint, but I think he's got it in the right range. I think
And
that
Joanne, I
supports
was going
that.
to comment that there's some evidence growing from some health systems of examples where it's not costing more
Right.
to implement these changes. To reinforce Robin's point, Kaiser Permanente, for example, in California, is building a lot of evidence-based design and safety measures into their hospital standards, and they're building a lot of hospitals now. And they've come up with a way of doing it that does not cost more at the front end cost. That it's about other choices that you make as well, and then smart management of the overall project, and a lot of other factors. So it's not just about the evidence-based design or sustainability or safety elements. But in addition to all that, it's sort of the wrong question. It's the wrong equation that's being looked at. It's not short-term return on investment and what do you purchase right up
Well,
to
that
the
was
bat.
the next question is okay, so
It
maybe
really
it costs
should
more,
be-
maybe
it-
it doesn't,
but-
but what's my payback over time?
Over the time. That's exactly right.
But
So
where does
you-
it come? Tell me specifically. You know,
in
let's say
operations and in safety, that you have better outcomes, you have higher satisfaction.
Go through one patient. Pick a patient. Tell me an anecdote about a patient who's going to have a better outcome because of the design.
You know, Roger, you may be better.
All right. Suppose we have a patient in a well-designed hospital that's sustainable, built according to evidence-based latest principles. That person's in a single-bed room, doesn't have a roommate. That means that person is at significantly lower risk, depending on their condition, usually significantly lower risk for hospital-acquired infection and for many categories of infection. It means for sure, with absolute certainty, that patient is in a less stressful, more relaxing environment with respect to the fact that it's far quieter. Most sound in multi-bed rooms comes from roommates and caregivers administering to roommates. That means they sleep better. Sleep is not only just nice to have, it's a very important outcome in and of itself. And disruptive sleep worsens recovery rates on various indicators for patients. It means that patient can far more easily have their family visiting, which helps to reduce stress, increase satisfaction for everybody, and helps ensure they're getting positive stress-reducing, healthful social support, and not stressful social contact from strangers or a stranger patient who may be in much pain, keep them from sleeping and so forth. And there are a host of other benefits in terms of privacy, confidentiality. Their outcomes will be better. Nurses caring for the patients will report higher satisfaction with their work, especially if nursing stations are also designed appropriately. And this produces higher workplace satisfaction and may be a factor reducing the terrible and costly problem we have of turnover. Keep in mind that some of these outcomes, and many others that I've not mentioned, some of them I've mentioned, have huge price tags associated with them. If we can prevent a patient from acquiring, for example, MRSA or methicillin-resistant Staph aureus, we're going to save several thousands of dollars, tens of thousands of dollars. Will help cut the number of days dramatically that patient, if they're high acuity, spends in the intensive care unit, et cetera, et cetera. And we may save the patient's life. So these are huge benefits, and the payback is quick. And at the risk of prolonging this, let me give one brief example of a rather dramatic, documented, published payback situation. Karolinska Institute in Sweden, in Stockholm, one of the world's leading medical research centers, the home institution for the Nobel Prize in Medicine. A group of us carried out a study of the effects on patients in coronary intensive care, suffering, of course, from acute myocardial infarction, of what we asked, what would be the effects of making their environment more positive acoustically simply by installing high-performance sound-absorbing ceiling tile as opposed to having sound-reflecting, lower-cost surfaces that were okay with according to codes. We did a rigorous prospective study in an experimental matter that's published in a leading cardiology journal. Another article is published about it in an occupational safety journal. We found that the payback time for that upgrade was less than 1 month, because not only did it improve sleep and reduce stress, it reduced blood pressure and substantially reduced the rate of rehospitalization on an emergency basis for those patients, that is post-discharge for those patients cared for during the good acoustics. Basically, preventing even one rehospitalization paid for the cost of upgrading the acoustic tile, not only in the patient spaces, but throughout the cardiology department more generally.
Bob, let me ask you, with the Global Health and Safety Initiative, you're trying to convince people of things like this. What kind of reaction do you get?
Well, it's very favorable. We have some of the leading health systems in the country coming together and working with a coalition of other partners from some nonprofit organizations, Center for Health Design, which these two individuals are on the board of, Healthcare Without Harm, Practice Green Health, and others, and with government agencies like the Department of Energy, who is here tonight, and a number of other organizations you talked about, to really build a social movement around the kind of change that is needed to implement not only safer buildings, which is really important around the planning and the organization of the buildings, but also the sort of the materials that are used, the products and goods that hospitals buy and use in their institutions, and how they operate. And so in doing all that, we're getting a positive understanding that there really is a linkage between the sustainability green movement and the sort of traditional interests of hospitals in patient safety and workplace safety.
No pushback.
No, I wouldn't say no pushback, because there's the question of, how do you do this on top of all the other pressing issues that are in society and with healthcare right at this moment. And so there's a real concern, but there's a growing interest that healthcare can really play a leadership role in helping to define the changes that are necessary, not only in its own industry, but also that can have ramifications for others and really add to the health of the community.
So what are the challenges there for getting the movement? It's clearly going, but for getting it going even at a higher level.
Well, one challenge is the recognition that this is a key element and one of the key questions really that society has to face today, I think. And getting this to be a priority area for within hospital, within government, really within society, that we think about things in a different way. There's a chance to do things right based on the knowledge that we now know, and the interconnectionness and intersection between a lot of how we plan, how we build, how we use products, and think about it in a long-term life cycle sort of approach. And if we start to do that, then I think we can really fundamentally change not only what we're building, and it's not just hospitals, that has ramifications throughout the entire built community, but really, the size and the type of those, and improving community health and making healthier spaces for people to live, and less impact on energy use. We're concerned about climate change, and all of this can have really positive reinforcements for that. So that's where we need to head. I think that the danger, of course, is that we don't recognize some of these issues and look at them as either isolated or don't do enough to make the significant change that's really needed at this time.
Robin, you're out in the real world trying to sell designs. No pushback there either?
Well, I think people are in this market, there's always a competition for a limited pool of resources and lots of competing interests for the pool of resources, whether those resources are monetary or whether they're global resources, right? And we are always trying to balance how to mobilize the right resources for the issue at hand, whether it's building a building or safely operating. But I think that Bob raises a good point, that healthcare is uniquely positioned relative to other market sectors in that they do represent so much of the gross domestic product and so much of the construction activity in the United States that I think now the real work of the Global Health and Safety Initiative has been to really mobilize the upstream leverage of 20% of the GDP towards smarter, better building products, towards smarter, better purchasing. That's
When you say 20% of the GDP,
Not yet, but headed
Not
that
yet.
way.
not
We're
yet,
what,
but
like
headed,
16%?
headed that way,
Right.
right? And to really begin to look at what the major supply chain issues are, and from an environmental perspective, from a safety perspective, and work on those issues for the health benefit, for both their own economic benefit but also for the health benefit of people in general. And then I think also the reality is that healthcare is also uniquely positioned because of the downstream influence, that people who encounter the healthcare system do so at a kind of vulnerable point in their lives. And so healthcare really is creating educable moments in a period of chronic disease. And so how healthcare models healthy behavior and healthy lifestyle. I think the Fable Hospital project that the Center for Health Design did pointed out that people judge their healthcare experience first and foremost on the totality of the experience of receiving care in an institution. They don't just judge the medical performance, but really every experience they have inside a hospital, from the moment they get out of their car in the parking lot, to the food they eat, to whether there's a recycling bin in the room, to the entire profile of care. And so how hospitals respond in this generation to creating an experience that models the change they'd like to see in health of people is really a pivotal connection. And I think it's been a slow one for healthcare to make, but in this era of focusing on the patient experience and focusing on the systems that support that experience is a moment for transformation, and hospitals are doing it in a fairly remarkable way, whether it's through their food purchasing and beginning to put organic and healthy meals in front of patients, to implementing recycling, to using greener cleaning products, and then helping patients model greener cleaning in their homes when they leave. It's all a real cycle, and it's a health-based cycle. So it's fabulous to see a huge sector of the economy beginning to stand for that, for all of us as consumers.
I was telling Roger, I told a friend of mine that I was coming over here and what we were going to be talking about, and she told me a story about a friend of hers who found herself in a strange city, had an emerging medical problem, went to a hospital, and once she got settled, was able to call around and talk to some of her friends, one of whom's father was a trauma surgeon in that city, and when he found out, he said she needs to leave that hospital, she's not going to get good medical care. So her friend told her this, and she said, "No, I really like it here." She said, "It's very pleasant, the staff seems happy, I'm very comfortable, I'm not going to leave." And I was thinking, boy, the hospital CEO needs to hear that. It doesn't matter about the doctors. She felt safe and secure because it was a pleasant environment, and she stayed there. I don't know what happened at the end of the story, but she stayed there. Let me ask you the big question. We're in Washington. Things are changing. Who knows what shape healthcare reform is going to take, but it looks like, yet again, looks like something's going to happen. How do you see, a movement towards green hospitals fitting into what could be changing in the next few years in healthcare? Is this move for reform going to change design? Are people going to have to look at these issues, or are they going to be able to continue on and sort of wait till it hits them on the head?
I think they're going to absolutely have to look at these issues. The healthcare system and its costs as we have it now, and actually its outcomes, are unsustainable. We aren't getting the value out of healthcare that we deserve to for the money that we're expending, which, as I'm sure you know, is significantly more than what is spent in other countries, yet we don't have the better outcomes to show for that. In fact, we're down pretty low in a number of the variables. And the whole sustainability approach and what that fosters of looking at things in a sort of a more life cycle approach, looking at evidence, taking a longer viewpoint, look at this, linking that to sort of the health of the population and safety outcomes. If that's the paradigm, and that's what all of us are talking about, that's a much smarter approach to looking at this question, and ultimately will lead to significant cost savings. So it's got to be part of the healthcare design and healthcare reform. In addition, I think healthcare reform question is going to move to start to question some of the things that we're paying for currently under healthcare. We really have more of a sickness care system than we have a healthcare system, and we aren't focusing on what is done to sort of keep people well and healthy and approach things from the preventive side and early detection side as much as we need to.
How do you do that in the design of a hospital?
How would that affect the design of a hospital?
Or how do you link the two? You know, that we need to look at, you know, we need to do more preventive care, we need to really make people healthier. With a hospital design, what do you do?
There's a whole question about what kind of hospitals we need to build, what size are they, where is care given, what's the mix of care already, driven largely because of cost more than other considerations. There's a huge shift to providing care on an outpatient basis rather than in hospitals. So procedures that would have been in a hospital just a few years ago are now increasingly done on an outpatient basis. Because we don't really, not only can we not afford the healthcare system, we don't really have the capacity or capability to take care of the patient projected load that will be coming. There's more experimentation about doing home care kind of resources or technological advancements of where you can do monitoring from afar or telecommunications and conversations with doctors, all of which fundamentally change what kind of buildings are we building and what size and how many even do we need of what types of hospitals. So it relates very directly to design issues and the size and types of hospitals in that way, and I'm sure my colleagues have even more examples.
Well, Robin, you've had examples in your book of just hospitals where it was easy for families to come in, you know, things like that. What are some of the other design issues you want to see?
Other design issues. Well, you know, it's interesting that we've gotten this far into this conversation and not actually talked about energy at all.
Right.
I definitely want to get to that.
And so it feels to me that I want to go back to this idea about transformation for a minute, that while we have talked about healthcare being in an era of transformation for a long time, and that the buildings are always transforming, we think, right? Because we're innovating along a kind of simple innovation curve. I think we really have to stand back and look at the hospitals and think about how we fundamentally shift the paradigm of design from an era of cheap energy and cheap fossil fuel to, and actually resource abundance, even in the other natural resource world, to how we would solve this problem of providing, good health care to 300 million people in an era of resource scarcity and expensive energy, and whether we would create the same systems that we currently have. And so I think that's actually a kind of fundamental leap that I think we stand at the edge of seeing what it takes to deliver quality health care under these very different circumstances. And my sense is that we're doing a good job so far, and the early adopters of sustainability work have done a good job of reducing their energy footprint and doing a better job on materials, and they're kind of in the do less harm world, right, of kind of ratcheting it down. But I really think the question of, are there other solutions to the way we provide health care that would fundamentally change the game is the question of the day. And so we can talk about some of the more interesting innovations that both support the idea of hospitals continuing to provide good health care, but becoming more attuned to community issues and becoming more integrated in their communities in times of stress is a big one. I also think that one of the obstacles has been that you can't manage what you don't measure. And healthcare hasn't really measured its ecological impact. It hasn't, many hospitals don't even meter their water use. Like we're talking about a whole system that is largely unquantified. Like you have some broad data from the Department of Energy on energy usage of the sector as a whole, but there's very little way to grasp the overall impact on the environment or on health of the performance of the healthcare system. And in fact, actually, the National Health Service in the UK has probably done the most of that, with really some surprising cathartic results. Recently, they published an ecological footprint of the National Health Service in Britain in 2001, where they said that 60% of their impact was the supplies and the materials surrounding doing healthcare, and only 20% of their impact was actually the direct energy use of the building. And then there was another 20% that was transportation, getting people to and from their facilities, if they measured their ecological footprint, as it were.
Is it that their energy impact is low or that everything else is high?
Good question, right? A little bit, certainly the energy usage in the UK is probably half on a
And they don't heat.
right, of what we use in the US. But nonetheless, they actually just repeated it in 2006, 2007. And one of the more fascinating pieces of data that they came out with is that literally 1/3 of the impact associated with the stuff, the materials and supplies, related to pharmaceuticals. Right? And it actually, the ecological impact of pharmaceuticals was completely dependent on where they sourced them. Were they pharmaceuticals made in Europe? Were they pharmaceuticals made in China?
Well, no, the only way you can design around that is to design a building where you will need fewer drugs. You won't need a sleeping pill if you've got your own room.
Right. Yeah, fewer drugs that you can safely dispose of.
What else can a
But it's
hospital do?
fascinating that while we tend to put our lens on the built environment, right, and that is, of course, the really primary topic of tonight, the bottom line is that when you start measuring, it's questionable whether the greatest impact on from sustainability measures is by shifting the building typology, right? It kind of goes with, I know. But one of the things that I mentioned in that book is that the primary way people engage in this work in the healthcare industry in the US is through operation. A lot of the earliest hospitals to do green buildings were hospitals that started by trying to green their operation.
And what started that movement?
I think it was actually the EPA finding that medical waste incineration was the second largest source of airborne dioxin in the US. And so in 1996, there was a kind of memorandum of understanding that launched the American Hospital Association with the EPA, resulted in the beginning of Hospitals for a Healthy Environment, a nonprofit that worked with hospitals on pollution prevention and is now reincarnated as Practice Green Health. But there's kind of a 10 to 12-year history, as it were, of this kind of evolution of pollution prevention in healthcare that a lot of the early adopters of green building built on. And when I thought about why that was in writing the book, I actually used an analogy from broader industry, which was an analogy that said that certain aspects of corporations, for-profit corporations in America, can put a green roof on a factory that makes SUVs and say that they're environmentally sustainable. But healthcare organizations don't get away with that. They're embedded in communities where they're held to a higher standard of care. And so I think many hospitals said to me early on, well, we can't build a green building if we still have styrofoam cups in our cafeteria. People will laugh at us. We can't build a green building if we don't have a recycling program, because people are going to say, well, you might have built this green building, but look at your garbage. So I think in healthcare, there's been a kind of much more integrated movement of operations and building And it's actually opened up whole new avenues of or areas of inquiry for people who work on buildings, like in the architecture and design community. I mean, I bet if I polled people in this audience about how many of you have had green operations conversations with clients in designing a hospital building different from what you had 5 or 6 years ago, I think a lot of people would probably raise their hand, right? Do
Let's
people
try it.
Believe that? Yes? No?
I'm not seeing many hands. You got the
interesting.
question? More conversations about greener hospitals?
And designed to support
Okay.
green operation, right? More conversation in that way. And that's a real sea change.
You know, let's go to questions now from the audience. We'll break one more time for questions, but right now, is there anything you want to... Scott is out there somewhere with a microphone. Okay, I see one right up here. And right in the front, the second row. And if you wouldn't mind identifying yourself, that'd be great.
Hi, I'm Whitney Austin. I'm from Johns Hopkins School of Public Health. And thank you very much for your discussions today. Robin, you mentioned you can't manage what you don't measure. And Roger, you made the comment about the huge issue of turnover, nursing staff. So I'm a doctoral student interested in evaluating a hospital that's decided to use green building practices. So what advice do you have for myself and others in an area which I think is emerging but extremely difficult to find support in at this time, about how to evaluate, how to go forward, who do we turn to for that support, and then finally, how the evidence that we find can be translated into practice?
Great question.
It is a very good question, and there's not a really short, adequate answer for it. Assessing effects or benefits, potential benefits for staff of green building innovations, upgrades, whatever, is difficult. It's scientifically difficult. It can be done, it's fairly straightforward for a limited number of topics, but for the most part, it's complex. The reason is green building interventions or design gestures typically involve a whole bundle of things. There's many variables involved. It's a lot of things are changing: lighting, air quality, the materials, etc. And it depends on how broadly you want to define sustainability, or whether there's a window view of nature or access to a garden, etc., etc. And so if one group is assigned to that set of conditions, and another group, ideally it would be the same people or somebody who are virtually identical or very similar, are assigned to similar conditions without that bundle of interventions, and then you find some difference over time in retention, illness, sick leave, whatever, then it's suggestive of an effect, a beneficial effect. And you certainly, in the case of retention, turnover, and so on, can immediately assign very large dollar numbers to those benefits. There are, but for the most part, let's realize at the outset, the number of randomized, controlled, prospective trials are going to be few and far between, because we're not talking about one single slice change and isolating the effects of that. We're talking about, well, for that, this is not unique. It's like most of safety-oriented changes in medicine. 100,000 Lives campaign, the surgical bundles for safety, they are literally bundles, and we haven't precisely disentangled the effects of each component, but the bundles work. And I think if you can have that as a goal, a bundle of green interventions, and associate that in a convincing way with changes, beneficial changes, then fine. I work usually with patients. In some ways it's easier. If you have more patients, they're turning over. But my advice would be, first of all, I think it's a wonderful direction, and I want to strongly and really give you my strongest personal encouragement. There are a few issues that are amenable to very rigorous prospective studies. For example, whether they have exposure to daylight, whether they have exposure to broad spectrum, bright artificial light, whether they have exposure to gardens, and so forth, which can be done in a rigorous fashion. And there is evidence from many studies now suggesting, for example, daylight is a common denominator, very positive environmental factor across any building type for staff, including conspicuously healthcare. By the way, that implies design challenges as we become higher tech in healthcare with more deeply submerged imaging spaces and so on, where we have these mole-like high-tech people working away without any access to daylight orientation at all. Also, there's recent evidence that is consistent with evidence for other building types that window views of nature are extremely satisfying for nurses. One good study recently, and are associated with lower stress, higher workplace satisfaction, and that may set the stage for reduced turnover.
Other questions? Right here.
Hi, Tim Stevens. I'm a health consultant with Briscoe Associates. I guess my question would be about cost shifting. I mean, the healthcare system is notorious for that, and I just wonder if you can tease out some of the issues around that for your work.
All right, who wants to tackle that? Bob? Can we get you to
Well,
tackle
I
that?
was thinking about cost shifting. You know, in some ways, we haven't really, this is probably not exactly what you're asking, but we haven't measured the true cost of what we're doing in healthcare or in society very adequately at all. And so the current debate about cost shifting, while it's really significant and there's important parts to look at, is only part of the equation. I mean, what we've done is shifted the burdens of society onto looking at sort of what do you do at a treatment stage, and then arguing about sort of who is paying for what part of that treatment cycle. And that's not really the whole question, or even I would argue the most germane question. It's really understanding what are the social costs of having things like where we're using fossil fuel in the way that we are, where we know that it has certain health ramifications to it, but we haven't counted that cost at all, you know, or the economic costs associated with climate change. We're only now beginning to understand all the areas of how this can ramify and affect you know, the populations and lead to public health sort of issues, from things as far ranging as food supply, the oceans, forestry, much less the normally attributed things like changes in severe weather conditions, and that leading to asthma and other breathing problems and other health things. So when we start to sort of factor those in, I think we start to get a different answer about what is the cost shift between that. So it is relevant to the work that we're doing, in the sense that we're trying to argue, at least with the Global Health and Safety Initiative, that you have to look at this very broadly. It's important to think in a long-term life cycle aspect and really understand the root causes of issues and problems. And then on the flip side of that, what are the potentials for changing that dynamics and that equation by looking at things like community health, population health, prevention measures, and building that into the design, not only of healthcare facilities, but of communities that we live in and how we have our sort of social policies aligned.
See, I still think you have that bucket problem, a different bucket problem or different bucket issue. If you have savings from this bucket, and you've still got a deficit in that bucket, the savings don't move. You know, they may go to the county that runs the hospital, but they don't go to the health insurers who are insuring patients there. In other words, you need people to look at this globally.
Yes.
But people tend to look at it based on what's in their checkbook,
Right.
what they're writing checks for. How do you have to change the financing system to do that?
Well, I think the financing system is going to change the argument. It's really the reverse, that the cost pressures are so great on the United States system now that it's ultimately not sustainable. It's leading to the whole discussions about healthcare reform that is generated once again now with the Obama administration. You see coalitions of businesses and the whole industry demanding changes because they can't afford it. You know, healthcare has become the major growing cost factor in their operations.
Well, yeah, and you see the unions joining with AARP, joining with
Precisely.
the businesses. And that, I mean, that is what it's going to take, and politicians are going to have to start listening to these coalitions instead of listening to just one group or another, because it's only at the coalition level that you're going to see the savings.
Right, and you talked about sort of different buckets and shifting from one to the other. The good news is that there's ultimate savings if we do it right. That it's not just shifting from one bucket to
Yeah, but if you
another.
own this bucket, you don't care about what's going on in the next one.
Well, I think as a society we're going to have to, and that's what is sort of being forced upon us, and hopefully more enlightened people are getting there and doing it on their own. But ultimately, if we continue down the path that we are going now, it's going to come crashing down and people are going to be forced to make changes.
I want to go back to the energy issue, because I think that, Roger, you had some more ideas that we were talking about upstairs about it can, if you don't think about it right, energy issues can conflict with patient safety issues or even community safety issues. How do you balance all that out?
Well, let me first comment that one of the hallmark trends, in my judgment, about our healthcare system or any modern healthcare system is that patient acuity is rising and is rising fast at all levels. That is, patients are just sicker. Patients are sicker if they're home-based. Patients are sicker if they're in general medical surgical units. Patients are much sicker now in intensive care, the sickest group, than they were 10 or 15 years ago. In fact, if you walk through an American general acuity, average acuity inpatient unit today, you'll see lots of patients who wouldn't have been there 10 or 15 years ago because they would have been in the lower end of high acuity or the ICU or intensive care. And if you go to the intensive care unit, you'll see lots of patients who wouldn't have been there 15 years ago because they wouldn't be alive. And this has meant that the intensity of care has had to increase at all levels. And it has meant that patients at all levels are much more vulnerable. And so we have to protect them more when we're putting them in an environment, whether it's an intensive care unit, general medical surgical, or even in some cases home-based environments. One hallmark of higher acuity is, or one indicator of high acuity is how much is the percent of people who are immunocompromised. It's an indicator of how many are on chemotherapy, strong steroids, or treatments, or having conditions which suppress or render dysfunctional their immune systems, which makes them, for example, sitting ducks for pathogens that ordinarily would not be a problem for them. The upshot of this is that higher percentages of our patients have to be put in environments which are exceptionally energy intensive just to protect them, with lots of air changes, and increasingly with lots of filtration or HEPA filters, which you can't get that kind of pressurization, or with directional pressurization to protect the people in adjacent spaces from the patient who's infected with something that's airborne. This is really basic, and the demand and the imperative of this is increasing. So we might think of a very rough positive correlation, but still pretty strong, between rising acuity, and there's no question it is, and increasing demands for energy. It's one reason that hospitals are energy mongers. So when we talk about cutting energy, we have to do it in a very smart way. We have to find sustainable, it's more imperative than ever to find sustainable design directions that are successful with respect to energy, in addition to all the other criteria. But at the same time, we keep always in the center of the radar scope patient safety, and how can we do this? We need to think about these kinds of issues.
Can you give an example of any solutions?
There is under testing in the UK and the NHS, and has been since about 2005, 2006, a kind of neutral pressurization ICU room for safety when patients are infected with something that can be easily transmitted to others.
I mean, instead of positive, just take it down a little bit?
A kind of neutral, I'm not a ventilation engineer, but there's been a real attempt to try and come up with a more energy efficient solution. Or look at the issue of patient, if I'm just sort of shifting here a bit, patient safety from the standpoint of medical errors. it makes compelling sense to reduce light levels or shut the lights off if we're not using the spaces. But when lights are turned down indiscriminately and ambient levels are lowered indiscriminately in a kind of sledgehammer way to save energy, including in workplace areas when the nursing population is now of an average age of 48 and our docs aren't so young either. What happens when you turn 40, by the way? I don't have my
Yeah, I've got
glasses.
mine right here.
Have my glasses. I got glasses, and like the great majority of the adult population in any country with normal vision, to sustain the same level of acuity, I need higher illumination. That's why it becomes more difficult to see at night when you're driving. You have to click on the high beams where before you didn't. Okay. The upshot is, it's very well known scientifically and ergonomically and so on, that as people age, they need higher on-task lighting to perform detailed tasks of writing, data entry, and so forth. So we've known for years, reflecting this, for instance, that older pharmacists in prospective trials make more errors, a lot more errors in dispensing medication when we lower the lighting levels on task. So here would be a smart implication that would be a way to fix this. Turn down the lights, save energy, but make sure you provide very bright adjustable task lighting over work areas on a selective basis so that our aging workforce can perform small paper and pencil detailed tests, not just in an energy-saving way, but in a safe way. And it's encouraging that ARC, the agency, the federal agency for healthcare research quality, has picked up very much on these kinds of relationships between the designed environment and patient safety, and has been writing about it.
And both of you have comments, so let's start with Robin, and then we'll move to Bob.
Well, I sort of want to challenge that diagram a little because...
By all means.
The acuity diagram?
Yeah, the acuity diagram and energy, right? I don't debate that there's rising acuity in U.S. hospitals. I think there's rising acuity in hospitals worldwide, right? It's not just a U.S.
Well, as medicine
phenomenon,
gets better,
right?
people...
I thought
right.
I made that point.
And not every country has that diagram, right? And I would argue that this diagram is more the result of cheap, highly subsidized energy than it is the need. Because we all know that when energy jumped, when gas prices went to $4 a gallon and oil was at $140 a barrel, suddenly lots of heat recovery systems were showing up on projects that had never had them before. And so the energy consumption or the energy intensity dropped back down. The fact is that we do have technology and we do have the ability to slacken that curve fairly dramatically. But in the bucket problem of capital and operating dollars that has been so bifurcated in healthcare, it's not been, and with oil at $40 a barrel and gasoline at $1 a gallon, it's been impossible to make the argument. And so what we've done is simply add more equipment, add more energy intensity, put another HEPA filter on the HVAC and lower its efficiency by, 15, 20%. But so we need a new way of thinking about this, I think. And the fact is that we could all get up in the morning with a smile on our face, with healthcare being the second most energy intensive sector of the built environment, if the energy source was renewable. So it's not simply the problem of energy intensity. Like, we don't have to suddenly say, well, you can't have energy intensity. The bottom line, though, is you can't have energy intensity from coal-fired power plants. And so we have to solve this problem in a larger way. And we have to make smart choices as a society about where energy intensity is justified and what we want to use our energy for. And I would not argue that we don't want to use energy to save lives. But if in the process of doing that, we're making asthma rates higher and we're having these other unintended and externalized consequences that may wind up having draconian impacts on all of our health. Where's the bargain in that?
Well, see, now the people who are getting asthma from breathing in the particulates aren't going to sue for malpractice.
Well, you have a good point about that's another conversation.
Bob?
I was going to pick up on another solution, which is what Robin implied about renewable energy. A lot of healthcare leaders would be very interested in implementing renewable energy programs in their hospitals, but have difficulties financing that currently.
They have difficulties finding?
Financing.
Oh, financing.
Yeah, being able to put out the capital outlay for the equipment and the infrastructure to make that work.
Right.
And so Global Health and Safety Initiative with its partners, Practice Green Health and Healthcare Without Harm, have been having discussions about a renewable energy program that focuses on healthcare for a lot of the reasons we've talked about, that this is a really smart place to invest in, and to make to help hospitals invest in renewable energy, and that then by doing that you get all these benefits out of the consequences of reducing illnesses.
But now, since what is it, 80% of the hospitals are nonprofit? I can't remember the number for nonprofits. You can't do that through tax credits, right?
Right.
Yeah, there's no tax benefit for nonprofits, so
Right.
what they've been trying to do, and some hospitals have done it, is doing a kind of a package deal with somebody who supplies renewable energy to them, and they purchase energy in a long-term purchase agreement sort of approach and so forth. What we've said, particularly as we're in this economic downturn and there's stimulus money and now a bill being talked about for energy and so forth, why not invest some of that in healthcare and in hospitals, because and allow them to move towards renewable energy in a greater way than they have, and that this will have positive impacts, and it can show the health benefits of doing this as well. And it's because hospitals are such a high energy user now, it's a really smart place to invest the money in. It creates green jobs. It sounds like a win-win-win, don't
Is
you
it
think?
shovel ready?
Yeah, in many places it is.
It
There's
is
lots
shovel
of projects that
You've
are
got
ready to
everything
go.
lined up, and that's good.
Joanne, I sort of implied a question in my comments earlier. Where did all these people come from who are sicker and sicker?
Well, that's
And
another
maybe
question.
that's part, and we can, evidence-based design, sustainable design has learned a lot about how to design spaces for those folks, but why do we have all those folks? Where is this onslaught of higher and higher acuity coming from? Where are all those people in intensive care in the United States coming from, who are so enormously expensive? Aren't we spending something like 1.4, 1.5% of gross national product just in critical care?
Right.
Unbelievable. All right, part of it's aging. A big part of it is advances in medical technology, and that's very good. And a big part of it is unhealthy lifestyles. People, yes, kept alive longer by advanced medicine, who have multiple chronic illness conditions. Isn't it something like 25% of us now in America, 25% of the population has more than one chronic condition?
I think that's
Yes.
right.
And so that immediately puts them in a much more complex, challenging care category that's much more expensive. I think we're spending more than 80% of all our healthcare dollars on those folks with chronic conditions. Where did they come from? They come from asthma, some of the things that have been touched on. Big portion comes from obesity and sedentary lifestyles. Poor diet, and it comes right back to the community. So we can talk about these rooms, we can talk about these buildings and how to make them more energy efficient. And this is very important, and safer, better care that reduce help to meaningfully reduce the huge costs of care. But at some point, we have to look at the fact that our lifestyles in our cities are generating huge numbers of people at ever younger ages with multiple chronic conditions, because there is very little physical activity, very little walking, very little bicycling on a daily basis. We live in our cars in highly auto-dependent environments. So now we have, for example, an epidemic of childhood type 2 diabetes, which is lifestyle related, heavily tied to inactivity. So the agenda, more broadly speaking, of how to save energy, to reduce dependence on foreign oil, reduce dependence on the automobile, Even with mass transit comes more walking and physical activity, and all of this has been shown in research, especially in Europe, to reduce or to postpone the date at which chronic conditions, the frequency of, or delay by years the onset of chronic conditions. So those are other parts of the solution.
But I want to
Have
know
other
how you're doing.
constituencies, but that's what's feeding a big part of this huge challenge in the hospitals.
Can you do anything with the design of a hospital to look at those bigger issues, to look at obesity? Is there anything, is it setting an example, for example?
You want to go, Rob? Go ahead.
Well, you know, there's sort of two ways. There are physical environment interventions that work on that problem. It's everything from co-locating walkable, pleasant stairs to be in by elevators so that people have the choice to walk up the stairs or take the elevator. Usually the stairs in hospitals are like these dark places that nobody wants to go in. And often they're locked on the inside, right? So it's how do you create walkable stairs in buildings that are daylit, that are pleasant to be in, that are secure, right? How do you rethink distances and encourage people to have pleasant walking experiences, not disgusting walking experiences, because actually people walk pretty long distances in healthcare. But in a lot of those encounters, people would rather take the shortcut because, you know, it's not pleasant to walk. So it's how do we really improve the physical, there are physical environment interventions. And in fact, the city of New York, where I'm from, has actually been taking a whole package of those physical environment interventions and trying to get them put through the U.S. Green Building Council's LEED program as an innovation credit in the built environment. You know, signage about using the stairs instead of the elevators. There's a whole range of them. So that's one, that's the physical environment interventions. But I think if you look at healthcare, that idea of downstream influence, so that when hospitals, like Global Health and Safety Initiative member hospitals, or people who sign the Healthy Food and Healthcare Pledge that Healthcare Without Harm's put forward, hospitals that start investing in purchasing antibiotic-free meat, that they become game changers. You see large poultry producers removing antibiotics from all the meat they sell because the healthcare industry, which buys a lot of poultry, isn't interested any longer in antibiotics in their poultry supplies. So in that way, healthcare begins to kind of get at changing and shifting markets that have real impact on the health of Americans, and then in their ability to treat people with immunocompromised systems with the range of antibiotics that they have in hand and have the antibiotics work, right? So there's lots of these kind of cyclical moments. You probably have other examples.
You know, it's also how you use your facility that Robin was talking about. So the number of hospitals, some great examples of farmers markets where they're running them on their campuses or on their facilities, and the kinds of foods that they purchase for staff as well as for patients, and you know, sort of choosing healthier choices and encouraging local and organic where available kind of food sort of approaches is good. The role that healthcare is taking in sort of leading sort of some of this public health, community health sort of approaches, and doing that and seeing that as part of their institution, and that they do some, you know, like classes, health education classes.
But they're not reimbursed for that. How do you encourage that in a system where they're not reimbursed for that?
This is one of the things, this is a challenge, and one of the things that needs to be changed, and one of the issues that we have, the demand side is pushing some of that, where institutions and leaders are recognizing that they need to just be doing more around this because of how they fit into the community and the growing issue around the availability of providers in the future for this onslaught of demand for patient care, and that they need to readjust their facilities to include more outpatient and more sort of in the community and working with people in home. So I think it's partly, demand-driven and partly sort of cost-related, and then there's also people who get the equation right, that this really makes sense for them and their institutions.
I would see the opportunity there may be, again, speaking from within Washington and watching some of the political activity, there's been a big interest by Congress in the nonprofitness of nonprofits, and they may at some point be encouraged to do more community service.
Yeah, that would be great, and we would like to see the policies.
I'm not suggesting that.
But policies do need to take into account some of the things we've talked about earlier on the panel, that you can't just have a really hard and fast requirement that hospitals have to meet a certain energy reduction goal by such and such year if you don't also factor in the acuity of the patients and sort of how you need this, and the fact that there's nothing like Energy Star like rated medical equipment. It just hadn't been on the table. Manufacturers hadn't really thought about this. And until now, people are starting to ask the questions. It probably will move in that way. But right now, there is nothing like that, and there's huge users of energy. So that would be, one example. So we think the policies need to reflect reality, but then also really seeing healthcare systems as an integral part of their communities and one of the really safety net parts of society. And if the policies and health reform move in that direction, that'd be a very positive step.
We can provide wellness centers, and many of our facilities are. How far can that go, however? Ideally, our hospital CEOs and clinical leaders ought to be serving on planning commissions and working with urban designers. That's urgently needed. And just one rule of thumb I have is about a community's overall healthfulness in terms of the urban design is if a doctor in the hospital or in a primary care clinic gives instructions to his patient that they should get more exercise, that's just about everybody sooner or later, okay? Is it reasonably possible for them to get more exercise and comply with those exercise instructions as part of their day-to-day living without joining an exercise club or without getting Nautilus equipment installed in their home? Can they walk around the block? Can they walk to a store? Can they walk to a friend's house? Can they take a bus? Can they actually use their legs? Many of our communities, our newer sprawl-era communities, are not only incredibly energy intensive and wasteful, they're also very unhealthy from that standpoint. And we know how to fix that. And so here's where it needs to come together, and maybe it's some kind of federal policy, maybe it's state policies, maybe it's incentives, maybe it's encouragement to the not-for-profit center. I'll leave that. I think what we need to do is generally quite apparent and very urgent. Finding the way is perhaps more difficult.
I would also add that, many healthcare institutions have replaced manufacturing as the largest employers in their communities. And yet it's true that it's almost as if the industry hasn't really embraced that idea. They like to think of themselves as small scale and kind of community members. But the reality is that hospitals can drive mass transit development. They really have an important role to play in fostering more walkable communities because they're 24/7, they have a lot of staff, they generally have outpatients that come and go. And so just like the factory used to be able to kind of plant itself and be an economic driver that people kind of understood in urban design, healthcare can be a catalyst, I think, for better urban design. And I'm glad to see that it's evolving that way, that hospitals, I think, are making smarter siting decisions in the recent past. They're using their scale to drive some of those kinds of improvements. And I think it represents a sea change. in a
I'm
good
going to
way.
ask the speakers one more question, but first I'm going to take questions from the audience. And I'm just going to warn them that the last question I'll ask them is what they want this very educated audience to take home with them from the evening. You guys halfway or all the way there already. I'm going to ask them, when we're done with the questions from the audience, what their take-home lessons are for you guys. But let's first go questions from the audience. Right there.
Thank you. Sorry. My name is Julia. Oh my gosh, I'm so sorry. Okay, I'll make this brief. I guess what I take away from this the most is that we do need to couple the research and technology for the chronic diagnosing and treatment with technology that encourages energy efficiency. Because if we continue to develop technology and give research money for that technology that's going to help us diagnose these very specific chronic diseases, then it's not profitable for companies to develop technologies that are going to make people healthy. And I think that just gets to the root of the problem, the very awful problem about our healthcare system, that we are trying to make a profit off of keeping people sick. And lastly, I think we should take televisions out of patients' rooms.
Any comment? I would not want to rip a television out of a kid's room, honestly. Other questions? Right back there. We're making Scott work tonight.
Peter Pennington from Alexandria Economic Policy Commission. Sorry, Environmental Policy Commission. Yesterday I attended my father-in-law's 90th birthday party. He lives in his house that he built in 1947 when he got home from the Navy. Thankfully it's single floor, but he's right on the edge of having to move out. He doesn't want to go to assisted living or a nursing home because it's full of old people. And he doesn't want to go to hospital because it's full of sick people. Tomorrow morning I'm chairing a mini conference of planners on housing for 2020 to 2030. And it's just sort of linking what we're hearing tonight with previous talks that we've been to. When we talk about green building and sustainable building, should we not really be making all homes suitable for the elderly? You heard those awful statistics about the number of people that are going to go through the 65, 70 age group. Simple tricks like wall sockets being at dado height, door widths that can take chairs and so on, toilets where you can do a UE and back quite carefully onto the toilet seat without having to get assistance and so on. So with these huge numbers coming through, can't we do something with the homes that people live in to start off with?
I don't think you'll get much argument here on that.
I think there's actually a huge amount of work to be done in linking sustainable housing, affordable housing, universal design, so that people can age in place in communities. And I think that our generation is like shares a lot in common with your 90-year-old relative, that none of us want to go to the kind of long-term, the large centralized long-term care facility that many of us have visited with our grandparents or our parents. So I applaud that idea. I think there's other factors at work that are moving that way that make me optimistic about that. One is that the reality is that because of the sheer numbers of younger people in the US versus people and the baby boom generation retiring, and you know, whether the economy recovers or not in time, the fact is that for many reasons, I think that we will have to stay in the workforce longer than any of us maybe thought we would. So staying in vital communities makes that more possible. And I'm reminded that David Suzuki pointed out that people who were born before 1950, he's a biologist, he did a talk at ASHE, American Society for Healthcare Engineering. He pointed out that people who were born sort of before 1950 are the only people living on the planet that remember, in the United States and in North America, that remember what it was like to live in communities that weren't in ecological overshoot, which we entered in about 1972, where we were using resources faster than the planet could replenish them. And that there's a real role for that generation remaining in communities to again renew what it means to live at a consumption level that is sustainable. And that to me is actually a huge argument for keeping communities intact and allowing that group of people to age in place.
Could I add one aspect to that? I couldn't agree with you more, sir. But let me add just one footnote, and it's a bit of an unpleasant one, unfortunately, to it. Acuity, as I emphasized in comments earlier, is rising everywhere, including in outpatient contexts, nursing homes, and in home-based care and independent living. It's very clear the acuity is going up. What this means with part of this model, let's recognize now what must happen comes with that model and just get ready for it. I'm saying we should have that model. I completely agree with you. And it's the only good model we have. But here's what's going to happen and is happening. With more people cared for at home for longer periods of time at higher acuity, they are sicker, and many, if not most, on long, repeated doses of antibiotics. And these people are increasingly vulnerable and fragile because they're at higher acuity. You have in the community a perfect incubator for antibiotic-resistant diseases and for things like MRSA, Clostridium difficile, VRE, and all the rest becoming lodged in the community, which they are internationally. And we have to keep that in mind when we're designing homes and modifying and moving for long-term at-home residency and moving in this direction, or with e-medicine. Those countries which have some of the best healthcare systems, and certainly the safest healthcare systems, and are doing the best with respect to infection, and have pioneered home-based care and are arguably years ahead of us in certain areas, such as the Netherlands or Sweden, all have been much more successful than we've been in dealing with infection within the hospitals. But they have not been so effective, or nobody's found a good solution with dealing with this concomitant problem. As you get chronic, created by when you move chronic illness patients out of beds in the hospital, and in effect that's what we're doing, and it's the right thing to do, and we must do it, and they're cared for in home-based situations, it's inevitable that these traditionally hospital-associated things become mirrored in the home environment, and that's what's beginning to happen around the world. And so we have to design for that. And a lot of these evidence-based design gestures we now associate with acute, higher acuity hospitals are very applicable increasingly in the home.
Okay, we'll take one more question from the audience. You've had your hand up, and then we'll ask the final question. I'm guessing panelists will probably stick around for a few minutes afterwards.
Good evening. My name is Amelia Greiner, and I'm also, can people hear me? Sorry, this is weird feedback. I'm also a doctoral student interested in land use policy and health. And I was really interested in the comment from, actually, I think all three panelists, that there have been hospitals that have or could play the role in driving change around transportation, farmers markets. And my question is, how do you create the political will to do something like that, given competing interests and this tension between a focus on individual versus population health?
That's a It's a great question. If you don't mind, I can start with that, because that's precisely why we and our partners have formed the Global Health and Safety Initiative as just one example. And we've chosen a particular model to try to address exactly that. How do you get this on the agenda, and how do you shape transformative change in healthcare and in society? And the approach that we are trying is to get some of the leading healthcare systems in the country and have a relatively small group of healthcare leaders pushing for an agenda in healthcare that really links up sustainability and the green movement with safety and community health. So patient safety, workplace safety in the buildings, and then also the health of the community and the public health implications of that. And by doing that and really advocating for the kind of changes that we've talked about here in the built environment, in purchasing, in operations, in public policy, and some of the research that's needed to do that, we're hoping that we're going to be able to help lead the entire sector to change. And so it is, without question, competing with a number of other pressures on healthcare currently. But I think that there's some good signs that there's the potential, at least, for this to be recognized as the movement that it needs to be, and sort of change to sort of come about, because the leaders in healthcare are saying we need to make these kind of changes. We need to make this happen for our institutions and for the better parts of society.
Anything to add? Well, then let's just go down the row here and let's start with Roger. The take-home lesson for this group.
As you all know, the U.S. healthcare system is immensely costly, and it's unparalleled in terms of being wasteful. And by world comparison standards, for advanced countries, it's in definitely the lowest tier with respect to effectiveness and overall performance. In these times of financial crisis, and we've come to understand generally, or there's widespread recognition, that problems in our healthcare system, wastefulness and so on, are contributing to our fiscal problems, and certainly eroding, for instance, the competitiveness of American firms. And in this climate, where dollars are scarce, and there's fear and anxiety, and understandable reluctance to spend, let's try to keep in mind that rebuilding hospitals in sustainable, evidence-based ways so they're safer and perform better would be a very wise, in my judgment, very wise use of public monies. And by spending money now in some smarter ways, we can save money for for years and years, for decades, and help resolve or help improve lots of outcomes and issues. And so better buildings, even in a time of limited funds, and thinking about what's going on in those buildings with respect to urban design as well, or the reciprocities and interconnections. Those would be things that I'd appreciate if you take home.
Robin.
One of the essayists in my book, one of the executive directors of Healthcare Without Harm, has the most quoted statement in my book. I wish I had the most quoted statement in my book, but he does. And it's that hospitals can situate themselves in the ecology of their communities and act as a force for healing. And I think that's really a pivotal idea that resonates with people who read the book, people in the healthcare industry. Because in a lot of ways, it kind of encapsulates why people who work in healthcare work in healthcare. That's what they came to healthcare to do, is to heal, right? So I think it's a remarkable confluence when sustainability meets this industry in a way that so meshes with mission and goals. And in a lot of ways, the strength of the sector and its sheer scale gives me a lot of hope every day that this is the sector that can make a difference and can really accelerate the rate of change that we so desperately need. So what do I think healthcare needs from us to do that? Because I think they're ready to take it and run. I think we need to support research in healthcare that allows people to get at some of the most critical questions that Roger and Bob and I talked about tonight. What are the most effective energy systems? How do we transform the way we use energy? What is the right level of ventilation effectiveness, and how do we provide the best patient care at the right level in environmental impact, with the minimal environmental impact, with no environmental impact? Wouldn't that be great, right? To really be able to do no harm. And I think encouragement into the community benefit aspects of this that allow them to kind of leapfrog past the issue of being paid for illness and reward healthcare systems for being stewards of community health, and creating new benefit measures and new ways to think about what defines success. That's what the healthcare industry needs from us. And then I think they have great capacity, or we all, as part of that system, have a great capacity to actually make real change and actualize it.
And my comment would be that we have a chance to do this right and to get it right this time around. And that healthcare plays a very important role in doing that. And if you look at the sustainability movement, the greening movement, it's something that especially when you link it up with safety and community health, as we've been talking about this evening, are not just kind of nice things to be doing, but are really imperatives of our age. And it's a step that we have to take. And like Robin said, I agree that a number of healthcare leaders are really poised and wanting to move forward in this direction. So that's the good news. But it's also not just about institutions doing this. It's about you all in the audience and we on the stage doing this in our individual lives and advocating for it in our places of work. It really is a sort of an imperative of our generation and of our society and of our communities. And we all need to be active around this, areas of sort of improving the health and well-being of our populations and the environment. And so it is that marriage of environment and community health. And if we work on this together, all of us, we can make a difference.
I hope you guys enjoyed that as much as I did, and I think the panelists will be around for a few minutes. I've got Robin's book up here if anybody wants to come see it, and thank you very much for coming.